Good day, students and learners. Welcome to the National Museum of Radiography. We are now at the home of 14 galleries and hallway exhibitions consisting of 20th to 21st century records of radiographic evolution from the past until present time. Our destination for today is particularly the Panoramic Radiography section to discuss the history, concept, and principles with more passion and adventure. And without further ado, let us now go towards our first stop for today.
Good day. I am your first tour guide for today, and we are now at the very beginning of the Panoramic Radiography Gallery. Panoramic radiography is a radiographic procedure that produces a single tomographic image of facial structures, including both the maxillary and the mandibular arches and their supporting structures. This technique is also known as pantomography, pan meaning wide, tomo meaning slice, a cut or a section, and graph meaning to write. Aside from this, panoramic radiography is also termed as orthopantomography, parabolography, or rotational radiography. But before we dive deep, why don't we learn the history first, shall we? The history of panoramic radiography. When panoramic radiographs just started, they were made using basically two different methods: the intraoral source of radiation and the extraoral source of radiation. Let me discuss to you first the intraoral source of radiation. So, it is where the radiation or the X-ray tube is directed from inside the mouth through the jaws, and as you can see, the film molded to the outside of the face of the patient, demonstrated by the exhibit here on my left. No screen or slow-speed screen films are used, and on my right is the exhibit of the intraoral panoramic unit. Within time, however, the intraoral film method was abandoned due to, first, the limited space within the oral cavity to reveal all the necessary structures, and second, separate exposures were required for each of the jaws, which does not satisfy the Alara principle where the radiation dose is kept as low as possible to achieve the desired outcome. Moving on to the extraoral source of radiation. In 1933, a Japanese dentist named Dr. Hisatsugu Nomata was the first to demonstrate panoramic radiography in practice. As presented on the exhibit here, the curved film was placed inside the mouth lingual to the teeth. The patient would stay still while using a slit or a narrow X-ray beam that rotated around the patient's jaw to expose the film. Moving on, in the year 1946, a pioneer in panoramic radiography would be Dr. Irioveli Patero, a Finnish dentist who is known as the father of panoramic radiography. Dr. Patero's first technique used a long curved film reaching from one end of the dental arch to the other. It was placed in the patient's mouth. The exposure was carried out with an X-ray tube moving around the face at a steady speed and emitting simultaneously a bundle of rays, which was narrowed down by a slotted shutter. Basically, Dr. Numata and Dr. Patero had the same technique, but Dr. Patero continued to revise or continued experimenting with the technique. And in 1949, he discovered that placing the film extraorally results in successful images. So the extraoral films rotated by the means of rotating chair around a stationary X-ray source, which the schematic diagram shows. Dr. Patero called this technique parabolography, and this insight led to the invention of pantomography, the first tomographic method of radiographing the teeth and jaws panoramically. So I will leave you here with Ms. Rocha in order to discuss the indications and uses of panoramic radiography.
Let's discuss some of the indications of the panoramic radiography. Number 1 is for initial patient evaluation, for example, identifying the impacted third molars when a consideration needs to be given whether or it should be removed or not. It is also for determining the dental age estimation and it is frequently indicated when professionals want to evaluate tooth developmental abnormalities, trauma, and to assist and assess orthodontic treatment. Examination for intraosseous pathology or the evaluation of developmental anomalies such as cysts, tumors, or infections. And for the diagnostic challenges that require broad coverage of the jaws or for extensive diseases or lesions which cannot be seen in the intraoral radiographs. Moving on to the advantages of panoramic radiography. First is it has a low radiation dose. The effective dose may be lower than a full mouth survey in some cases. Second is it is a quick and convenient radiographic technique because the positioning of the patient is relatively simple and only minimal expertise of the radiographer is required. Third is it is a useful visual aid in patient education and case presentation, and patients can easily understand what the dentist is presenting, and it is a useful tool for teaching aid. And fourth, it has a broad coverage of facial bones and teeth. Large areas can be covered and all the tissues, including the anterior teeth, lateral floor, medial and posterior walls, are well shown, and also the condylar heads can be shown in one film, being able to compare it easily. And lastly, the disadvantages of panoramic radiography. Number one is it has a low resolution images, so soft tissues and air shadows can overlay the required hard tissue structures that are needed to be interpreted, and it doesn't display fine anatomic details. Second is the value of the panoramic X-ray unit is relatively high compared with the cost of an intraoral X-ray unit. Third is the technique is not suitable for children under 6 years or on some disabled patients because of the length of the exposure cycle with the risk of post-radiation cancer. And fourth is it requires accurate patient positioning to avoid errors and artifacts, because the movements of the patients during exposure can alter the image and can create difficulties when interpreting the image.
Hi, so now we will proceed to the exposure protocols here in the Panoramic Radiography Gallery. Panoramic X-ray machines have the following exposure factor controls. First is the kilovoltage or the kVp, next is the milliamperage or the mA, and time. Each panoramic unit has exposure factors that are determined by the manufacturer, and these are suggested in the instruction manual for the X-ray machine. For the kVp or the kilovoltage in dental radiography, it is best to utilize 70 kV or above. For the milliamperage, a setting of 7 to 15 mA is required, and for the time, which will control the duration of exposure, will only last for seconds. As shown on the paintings, we can see a 73 kilovoltage, a milliamperage set at 12, and a 13.9 seconds indication for time. Panoramic X-ray unit exposure is controlled by adjusting complementary parameters. Although predetermined, exposure settings for panoramic imaging are available. The milliamperage and kilovoltage settings are adjustable and can be varied to accommodate patients of different sizes. The exposure time is fixed, while the kVp and the milliamperage are adjusted according to the patient size, stature, and bone density as shown on the paintings. So for the last portraits of the exposure protocols, this depicts other X-ray units which offers wider parameters to better accommodate and personalize exposure settings. This may include field size, arch shape and size selection, and a ready button to indicate if the patient is a child or an adult.
Hi, now we move on to to the next exhibit, which will showcase patient preparation errors. Proper patient preparation is critical in obtaining a diagnostic panoramic image. For the first exhibit, Exhibit A, this painting shows failure to remove large ring-shaped earrings. On the other hand, Exhibit B shows failure to remove stud earrings. Both of these paintings shows a casting of two shadows, one real in focus solid arrows and one ghost which is in blurred open arrows. Exhibit C shows failure to remove necklace. This characterizes by blurred ghost shadow which is arrow. And Exhibit D shows failure to remove piercing in the tongue which is in large arrow and a piercing in the lower lip which is in small arrow. Exhibit E shows a failure of removal of the upper and lower metallic partial dentures. Exhibit F shows failure of removal of an upper orthodontic appliance. And lastly, Exhibit G shows a failure of removal of the spectacles as arrowed. All of the mentioned exhibits shows a ghost image. A ghost image is a radiopaque artifact seen on a panoramic image, and this is produced when a thick, dense object is located outside of the focal plane and close to the X-ray source. To avoid a ghost image artifact, the dental radiographer must instruct the patient to remove all dense objects in the head and neck region before positioning the patient for panoramic radiography. We now head to the last portraits of the patient preparation errors. Exhibit H shows inappropriate use of protective lead apron. This is too high on the neck, casting a dense radiopaque shadow as arrowed over the anterior part of the mandible. If the lead apron is incorrectly placed on the patient, a radiopaque cone-shaped artifact results that obscures diagnostic information. Exhibit I shows a thyroid collar artifact. Thyroid collars are never used since they would attenuate the X-ray beam and produce a white, non-exposed area on the radiograph. If a lead apron with the thyroid collar is used during the exposure of a panoramic projection, a bilateral radiopaque artifact results will obstruct the mandible. So to prevent such artifacts, the dental radiographer must always use a lead apron without a thyroid collar. The lead apron without a thyroid collar must be placed low around the neck of the patient so that it does not block the X-ray beam. So for reiteration, the two most common patient preparation errors are the ghost image, lead apron artifact, and usage of thyroid collars.
And here we are. We have now reached the proper patient positioning section in the Panoramic Radiography Gallery. To obtain diagnostically useful panoramic radiographs, it is extremely of importance to prepare patients properly and comfortably because of the length of time needed to acquire the panoramic image. In these photographs, we see the use of ergonomic handles and head positioning devices which allow for patient comfort while maintaining the correct position, and may allow for the patient to stand, sit, or use a wheelchair during exposure. To your left, we see the laser alignment lights by many panoramic manufacturers to offer guidance with patient positioning. These lighted lines allow the radiographer to easily visualize the mid-sagittal and Frankfurt planes. Some lights also indicate the correct position of the focal throw. Although each manufacturer's positioning and exposure instructions vary slightly from one another, there are some general requirements that are common to all panoramic imaging procedures, whether digital or film-based. For the first piece here to your left, entitled the position spine, the patient should be positioned to sit or stand as tall as possible with the shoulders back. From its name, the spine should be perfectly straight and instructed to remain still during the procedure while holding any stabilizing supports or handles provided. Children should be instructed to look forward and not follow the tube head with their eyes. And the next piece here to your right, entitled the position teeth, the patient should be instructed to bite in the groove located on the Paslik bite block. This aligns the teeth in the focal trough. The maxillary and mandibular anterior is positioned in an edge-to-edge position in the groove on the bite block with the chin in good contact with the chin support, while the head should be immobilized using the temple supports. For the third piece to your left, we have here the positioned head. Seen in this photograph, the laser alignment lights are positioned so that the mid-sagittal plane is vertically at the center of the patient's face, perpendicular to the floor. Also, in this procedure, the Frankfurt horizontal plane should also be aligned, passing through the top of the ear canal to the bottom of the eye socket, parallel to the floor. With the mid-sagittal and Frankfurt plane in place, the patient's head must remain still and not tipped up or down to prevent from errors to occur. On to the next piece to your right, we have the photograph of the positioned lips and tongue. Seen here, the patient is instructed to place the tongue on the roof of the mouth. One key to this is by suggesting the patient to swallow and feel the tongue rise up to the roof of the mouth, and keep the tongue in that position during the procedure. It is important that the patient maintains their lips closed around the bite block and not to move throughout the exposure cycle, which is approximately at 15 to 18 seconds. With all these photographic instructions in mind, the patient should remain still and maintain these positions while the machine is rotating during exposure. Now, with the patient positioning instructions being done, let's now go to the gallery of the patient positioning errors. Many positioning errors can be made in the slightest change of position in panoramic imaging. Due to the panoramic's wider scope of exposure, even the smallest change can create an obvious distorted image. And in the tissue projection errors section, we have first the errors in positioning the lips and the tongue, when the patient's lips are not closed on the bite block during the exposure of a panoramic projection. To your left, a dark radiolucent shadow results which obscures the anterior teeth. This area of increased darkness occurs over the maxillary anterior region and may be mistaken for bone loss. On your right, similarly, when the tongue is not in contact with the palate during the exposure of a panoramic projection, a dark radiolucent shadow results, which obscures the apices of the maxillary teeth. And through these errors, you would see how important it is to maintain and instruct proper patient positioning, and these errors particularly can be prevented by closing the lip and holding the tongue against the hard palate during exposure. Here now we are in the Frankfurt or occlusal plane errors section, which are caused by upward and downward head positions affecting the horizontal plane. And here we have the radiographic error entitled chin tipped up, which shows that if the patient is positioned such that the chin is too high or is tipped up, the Frankfurt plane will be angled upward, thus producing a reverse smile line. Along in this radiographic error, there are also other several evident manifestations, such as the condyles may not be visible or may appear near the lateral edge of the image. The hard palate and the floor of the nasal cavity appear superimposed over the roots of the maxillary teeth. The maxillary incisors appear blurred and magnified, by which a loss of detail occurs in the maxillary incisor region. To prevent such an error, the dental radiographer must carefully position the patient such that the Frankfurt plane, passing from the bottom of the eye socket through the top of the ear canal, must be parallel to the floor. Again, we always go back to proper patient positioning. On the other side, we have the radiographic error when the chin is tipped down. So if the patient is positioned such that the chin is too low or is tipped down as presented on the photograph to your right, the Frankfurt plane is angled downward, thus oppositely producing a more exaggerated smile line than normal. Along in this error, several key points are that the condyles are positioned higher on the image, the hyoid bone forms a single widened line, the mandibular incisors appear blurred, the roots may appear short, and a loss of detail occurs at the anterior apical region. And again, the solution to prevent the occurrence of this problem is through proper patient positioning instructions, particularly by carefully positioning the patient's head such that the Frankfurt plane is parallel to the floor.
Hello everyone, welcome. I'm Thea. I will be taking over the tour for this area. If you would please follow me. Here we see more from the same collection as previously shown by Ms. Chu. There are more errors presented here, and as we can see, this one is titled Teeth Anterior to the Focal Toit. You see, if the patient is positioned in such a way that the anterior teeth are not positioned in the focal toit, as indicated by the groove in the bite block, teeth appear to be blurred. If the patient's teeth are too far forward on the bite block or anterior to the focal toit, if you look at this photo to see an example, the patient is incorrectly positioned, the teeth have been placed too far forward on the bite block, and the anterior teeth present to be skinny and out of focus in the resulting image here. The anterior teeth appeared narrowed and blurred in the panoramic image when the patient's teeth are positioned too far forward on the bite block. In addition to this, there is a pronounced overlap of the premolars that can be seen. To prevent such errors, the dental radiographer must position the patient such that the anterior teeth are in an end-to-end position in the groove on the bite block. The forehead support must then be adjusted to stabilize the patient's head position and prevent the patient from sliding forward on the bite block. Follow me for the next slide, please. Okay, next, we see here the posterior of the focal toit. If the patient's anterior teeth are not positioned in the focal toit as indicated by the groove in the bite block, the teeth appear blurred. If the patient's anterior teeth are aligned too far back on the bite block or posterior to the focal toit, as you see here in the photo, if you look closely, you will see that the teeth have been placed too far back and not on the bite block. The teeth appear fat and out of focus on the image of the radiograph. The roots of the anterior teeth may appear to be cut off, and the anterior teeth appear widened and blurred on the panoramic image when the patient's teeth are positioned too far back on the bite block. To prevent this type of errors, the dental radiographer must position the patient such that anterior teeth are in an end-to-end position in the groove on the bite block. Now, let's go on to the next piece. This is called the head turn. It is part of the mid-sagittal plane errors, the horizontal kind. If the patient's head is turned slightly to one side and not centered on the bite block, as you see here in this image right here, the structures on one side are closer to the receptor while the structures on the other side are further away. As a result, the ramus and the posterior teeth on one side of the image appear larger than those on the other side of the image. The side furthest from the receptor appears magnified and the side closest to the receptor appears smaller as seen in today's radiographic image. For example, if the patient's head is turned to the right, the teeth on the patient's right side are closest to the receptor. The teeth closest to the receptor demonstrate the least amount of magnification. To prevent such an error, the dental radiographer must position the patient's head such that the mid-sagittal plane, the imaginary plane that divides the piece from right and left equal sides, is perpendicular to the midline and is centered on the bite stick. The lateral head supports what must then be adjusted to stabilize the position of the patient's head. Now, if we go to the last piece of this collection, finally, the last one on this series is called the slumped posture. When the patient is slouched, slumped, or not standing with the shoulders back, the X-ray beam passes through more of the cervical spine because the beam is angled upward at the negative vertical angulation of negative 10 degrees. The cervical spine appears as a radiopacity in the center of the image and obscures diagnostic information that we need. To prevent such an error, the dental radiographer must instruct the patient to stand or sit as tall as possible with a straight back. An additional instruction to the patient must include step forward slightly closer to the machine. This movement has the effect of straightening the cervical spine. And that is the last for this collection. Thank you for exploring these pieces for me. I hope you enjoyed and picked up some new information on my little section of this museum. There's more to learn from Ms. Membrat in the next section.
Hello everyone, I am Minya, your guide for this tour, and I'd like to welcome all of you to the National Museum of Radiography. Join me as we discover the ideal features of panoramic image and the different landmarks used. So first off, I am going to discuss this image beside me. This is a diagnostic panoramic image. A diagnostic panoramic image results when the equipment preparation, patient preparation, and patient positioning are completed correctly. The ideal panoramic image should be free from all errors in exposure, technique, and positioning. Such an image is not always possible. Minor errors may be present that do not affect the diagnostic quality of the image. In such cases, a retake of the panoramic image is unnecessary. A diagnostic panoramic image must demonstrate accurate anatomic features and proper exposure resulting in correct density and contrast. On to the next piece, I am going to talk about this radiograph entitled Image Projection. Panoramic radiography is based on the principles of tomography and slit radiography. Tomography is a body sectioning technique involving the simultaneous movement of the X-ray tube head and image receptor in opposite directions to produce an image at a depth of tissue. Slit radiograph, on the other hand, involves the acquisition of an image of a large structure by the scanning movement of a slit beam. These two processes produce a curved focal throat that theoretically corresponds to the average jaw shape. The anterior part of the layer is unavoidably narrower than the posterior part of the layer. Therefore, some patients' jaw will not exactly match the predetermined form of the image layer. Correct patient positioning is essential for optimal results. In general, image distortion occurs when structures are positioned anterior or labial, or narrows and blurs, posterior or lingual, or a combination therefore relative to the focal throat. For the third piece, you can see in this picture the ideal anatomic features of a panoramic radiograph. A panoramic image must allow for the visualization of the maxillofacial anatomic features that it represents. The panoramic image may be divided into 6 areas for review. Area 1 is the dentition. Teeth are arranged in a smile-like curve, and crowns and apices of all teeth are visible. In Area 2 is the ramus and cervical spine. The ramus should be the same width on each side, and the cervical spine may be present along edges but should not overlap the ramus. On Area 3 is the nasal cavity and the maxillary sinus. Hard palate dual image appears above the apices of the maxillary teeth. Area 4 is the body of the mandible. Inferior border of mandible appears smooth and continuous. On Area 5 is the condyle. Condyle is centered and is of equal size on each side and is on the same horizontal plane. And lastly is Area 6, which is the hyoid. Hyoid bone double image appears. Hyoid may slightly overlap the mandible. If any areas are obstructed, absent, or distorted, the image should be retaken. Each image should be assessed to determine if the dentition and bones of the maxillofacial region are representative. Assessment of acceptable dentition features includes the following. Anterior teeth are in focus with pulp chambers visible. Anterior teeth are not excessively narrow or wide, and posterior teeth on the right side appear similar in size to the posterior teeth on the left side. Assessment of bony anatomic accuracy includes the following. Both condyles appear on the image. The palate appears above the apices of the maxillary teeth and superimposed over the maxillary sinus. And the width of the right ramus is similar to the width of the left ramus. On to the next piece, this photograph shows you an overexposed and an underexposed panoramic image. The diagnostic panoramic image results from adequate exposure and exhibits proper density and contrast. Adequate exposure results from choosing the correct kilovoltage and milliamperage settings for the size of the patient. Smaller patients require less exposure, whereas larger patients require more. With an ideal panoramic image, the density or overall darkness is not excessive. An overexposed image, which is the image on the left, appears excessively dark with areas of burnout. On the other hand, an underexposed image, which is the image on the right, appears excessively light with areas of whiteout. An overexposed or underexposed panoramic image may cause problems with detection of unerupted teeth or bony lesions. It is important to note that with digital imaging, an overexposed image can be corrected with the use of software, but an underexposed image cannot. Proper contrast on a panoramic image is also critical, especially when multiple anatomic structures appear overlapped. Ideal contrast on a panoramic image should allow for the identification of the junction between enamel and dentine in the molar region. Inadequate contrast may lead to problems with detection of unerupted or impacted teeth. And for the last piece that I'm gonna be showing you, here is a photograph of a panoramic radiograph showing its landmarks. According to this radiograph, there are a total of 35 landmarks labeled by numbers. It is important to understand the landmarks normally seen on panoramic images in order to prevent misdiagnosis of a radiopaque or radiolucent area.
Now, let's go to the last part of the tour, and I hope you guys are still having fun. So for the last part of our tour, we will know how to assess the quality of the radiograph. So when we are assessing the quality of a radiograph, there are 3 different stages. First one is comparison of the image against ideal quality criteria. Second is subjective rating of image quality using published standards. Third, detailed assessment of rejected films to determine the source of errors. We use ideal quality criteria no matter the type of image receptors used. So here are some of the quality criteria that we will have to follow or assess. The first one is all the upper and lower teeth and their supporting alveolar bone should be clearly demonstrated. The second is the whole of the mandible should be included. Third, magnification in the vertical and horizontal planes should be equal. Fourth, only the slightest ghost shadow of the contralateral angle of the mandible and the cervical spine should be evident. Fifth, there should be no evidence of artifactual shadows due to dentures, earrings, and other jewelry. Sixth, the patient identification label should not obscure any of the above features. 7. The image should be clearly labeled with the patient's name and the date of the examination. 8. And lastly, the image should be clearly marked with a right and or left letter. On the image on your right, we can see red circles or oblongs, right? So these are the features of the dentition that we can use to assess if the teeth, particularly the anterior teeth, are positioned correctly within the focal. So, no or slight upward curve of teeth, no tooth size discrepancy on left or right side, anterior teeth in focus, anterior teeth shape should be normal, not too wide or too narrow. Premolars will always overlap due to inherent X-ray beam projection to the arc of the teeth in this region. On your left naman, we can use the condyles, which should or usually in the upper outer sextant and at the same level. So the right and left molar teeth should be equal in their mesiodistal dimension. The density across the image should be uniform with no air shadow above the tongue, creating a radiolucent band over the roots of the upper teeth. The image of the hard palate should appear above the apices of the upper teeth, and the ramus width should be very similar on both left and right sides. In addition to this, we have to assess the exposure of the image. We have to have an adequate exposure, which implies adequate density and contrast, which will help us to easily recognize anatomic features. Excessive or inadequate density can lead to failure to detect features such as an erupted or impacted teeth and or even pathology. So here on our left, we have an overexposed panoramic radiograph. When we have an overexposed image, it can lead to failure to detect pathologic features. Now, let's turn our focus on the right side. We have here the digitally enhanced version of the first photograph. We can see that there is a radiolucent region causing expansion and thinning of the interior cortex of the right mandible. So we cannot see this if the photo was overexposed. These images demonstrate how inadequate exposure can lead to failure to detect pathologic features. This image on the right is a digitally enhanced version and clearly demonstrates the appearance of an impacted mandibular right third molar that was not readily apparent on the original on your left. These are the subjective quality rating criteria. So we can say that the image is a 1 or excellent if there is no errors of patient preparation, exposure, positioning, processing, or film handling. While if the image is a 2, it is diagnostically acceptable, meaning there may be some errors, but it do not detract from the diagnostic utility of the radiograph. So if an image is E3, it is unacceptable. So the errors of patient preparation, exposure, positioning, processing, or film handling which render the radiographic diagnostically unacceptable. So after the subjective rating of image quality, we all now have to assess why the film or the radiographs was rejected. So there are different errors that we may encounter like patient preparation errors, patient positioning errors, equipment positioning errors. And all these errors are shown to you earlier by Ms. Obediente, Ms. Chu, and Ms. Palagan. So now let's see some samples of panoramic radiographs. So as you can see in the picture, this is from a 9-year-old patient with a mixed dentition. So this patient went back when he was already 15 years old. So through this radiograph, you can see clearly that there is a rotation of teeth 2-2, and this panoramic radiograph also provided a great visual to help the physician or the dentist to understand the current condition of the patient and how it compared to the imaging from 6 years earlier. So for our last radiograph, as you can see naman that the 221 was encircled. So it is because the patient came in complaining about their front teeth. So after taking the panoramic image, so it was noted that the tooth 21 had resorption on the root. So that's why if you are the dentist, you can also request for a periapical radiograph to evaluate the condition more closely. So that's it for our tour. So thank you guys for listening.